Thanks. So the next presentation is about section GG. And so this is the section called Functional Abilities and Goals. And in this section, the objectives at the time that I finish my presentation, I hope that you'll be able to define and the items included in section GG, that is the functional abilities and goals, that you'll be able to explain the new items and the changes, and that's actually the first part that we go through. And so it's understanding the differences between the data set version 2.01 and version 3.0. Also, I hope that by the end of the presentation, you'll be able to understand the intent of section GG items. It's all about function. And also, you'll be able to discuss coding instructions and the needed information for items. We will be going through some coding scenarios, and I hope that by the end of the presentation, you'll feel more comfortable coding some of the examples. I think as part of the instructions for attending today, the team did send out an email and suggested that you print out a copy of the data set. So it would be probably really helpful when we start going through the scenarios if you actually look at the data set so you have the definition, let's say, of the eating item and all the coding responses, and then that'll make it easier when you are asked to provide a response. Also, this section does tend to be fairly interdisciplinary, and so if you maybe want to talk as a team at the table, maybe you'll meet some new people as part of that too. And so if you want to maybe just have a team response, we'll try and do that to make it a little bit different than the other sections. So I wanted to start off again talking about what's new and what's changed between version 2.01 and version 3.0. So actually the answer to that's pretty easy. There's a lot of new stuff on section GG. So the new items are GG0100, prior functioning, everyday activities, GG110, prior device use, GG130, self-care, which has several items, and then section GG0170, the mobility items. In terms of changes, I think the most important thing that I'd like to convey is that the items are basically the same, except that the item numbering changed. So the items that used to be GG160A are now GG170A and B and C. There was a slight wording change made on GG017A. It's not changing the meaning, it was just a suggestion to clarify the language. So it's really not a change in terms of the intent, or scoring examples wouldn't be affected by that. So in terms of the intent, why are these items important? So as many of you know, part of the LTAC quality reporting program, there were several functional status quality measures that were added and adopted into the LTAC quality reporting program. And so the items that we'll be going over are used to help calculate those quality measures. So the items are, there's, I guess, kind of three major categories of items. So the first are the items related to prior functioning and use of device. And the time frame for this is really important to understand. So I'll reinforce this as we get through the items themselves. But basically, we're trying to get an understanding of the person's functional status prior to the current illness, injury, or exacerbation. So if somebody had a very severe brain injury or a very severe stroke and was admitted to, let's say, an acute care hospital and then to your LTAC, we're interested in the person's status prior to that stroke or brain injury. So I hope that makes sense. So it's prior functioning, prior to the current medical issue that's bringing the person to the LTAC. So that's one group of items. So those are in the category of prior functioning. The second group of items relate to admission and discharge, self-care, and mobility performance. So there are quite a few items related to self-care and mobility that you will, or your team members will be assessing on admission and discharge while they're admitted to the LTAC. So at the start of the LTAC stay on admission, and then as the person is about to leave, maybe in some circumstances going home, there is, again, an opportunity to do assessment of these self-care mobility items. So I'm just going to be covering those items together, and so the examples that I give could be admission or could be discharge. The scoring is the same. The third group of items that are on the data set that are new relate to discharge goals. So for patients who are admitted to an LTAC, setting functional goals may be very important, and especially if somebody is expected to improve, and so it will help inform the treatment plan, and the items are coded on the admission data set. So just to reinforce that, the patient, as they're being admitted, you will have some items related to their prior functioning. You will have items related to their admission status, and then you will, on the admission form, document at least one functional goal that is potentially achievable at the end of the stay by discharge. So that's why it's discharge goals. So again, the discharge goal is on the admission form. So the admission and discharge self-care items assess the patient's need for assistance with self-care mobility items. And so that's part of what we'll be covering when we go through the items and go through the scenarios. But it's all about whether the patient needs assistance to complete the daily activities. The items that are on the data set, I will sometimes refer to them as activities or daily activities. And the definition of activities is consistent with the definition of the International Classification of Functioning. And that definition is right on this slide. An activity refers to the execution of a task or action by an individual. Many LTAC patients have self-care and mobility limitations when they're admitted. And obviously, they're at risk for additional problems, further decline, as well as complications due to limited mobility and limited self-care. And that's why these items are really important. So to begin with the first set of items, that's section GGO 100. And this is focused on prior functioning everyday activities. So if you look at your data set, this is on the admission data set. It is only collected at admission. And as we will talk a little bit more, the items on this data set are important in terms of calculating the quality measures. And so understanding somebody's prior function was important as we looked at who actually experienced functional improvement as part of their stay. So this is one of the risk adjusters, and therefore it's only required to be collected on admission. So you see there is a 3-level rating scale, 3, 2, 1, and then there's also a couple of codes that can be used to indicate that it's unknown what the person's prior functioning status, as well as not applicable. There is only one item in this particular data set, which is B, indoor mobility. On some of the other data sets, for example, on the IRF-PAI, there are more items. So like A, I think, is self-care, but prior mobility was the only item that was relevant for this particular population. So again, the rationale, as I said before, function's really important. And so knowledge of the person's functioning prior to the current illness, exacerbation, or injury may inform the treatment goals and therefore the treatment plan. So in terms of the steps for assessment to gather the data, you can gather this data by interviewing the patient or family, or if the information is available in the medical records, because this was documented during the acute care stay, that's also an acceptable source of information for this particular item. So in terms of the actual coding of the item, and again, if you have the data set, it would be really great for you to pull it out, and if you want to mark notes on it so that it's kind of in one place for you, that's probably going to be the most helpful. So again, it's only on the admission form, so you should be looking at the admission form to find it. A code of 3 means that the person is independent, and that would be completed as a 1 if the patient completed the daily activities by him or herself, regardless of whether the person used devices. And again, this is prior functioning, so it's prior to the current illness, injury, or exacerbation. Code 2 is used if the person needed some help prior to this new event that started this episode of care. And this would be coded if the patient needed partial assistance from another person to complete the activities. And then code 1 is used to indicate that the person was dependent, meaning that a helper completed the activities for the patient prior to the current episode of care. If you are not able to get the information from the patient, the family, and maybe it's not in the acute care record anywhere, so it's possible that somebody is unresponsive, there's no family members who are able to provide this information, nobody was able to get in acute care, we do have the option that you can say the person, the information is unknown, that you were not sure if the person was able to perform the activities independently or dependently prior to the current episode. We also have the option of code 9, which means that the person, it was not relevant for the person, it's not applicable. So the person, let's say, was in a wheelchair prior to the current event. So in terms of coding tips, record the person's usual ability to perform indoor mobility, so ambulation, prior to the current illness, exacerbation, or injury. If no information is available, again, code unknown, code 8. The next few items are about prior device use. So again, it's the same time frame prior to the current event. Did the person use any devices? And so there are 3 types of devices that were found to be important in terms of our predicting functional ability and functional improvement. The first one being manual wheelchair, second being motorized wheelchair or scooter, the third being a mechanical lift. So again, consistent with the other item, understanding the person's ability prior to their current event is important in order to inform treatment goals. As part of your interview with the family or the patient, when you're asking about mobility, you'd also be asking about prior device use. And again, these are mobility-oriented device uses. In terms of coding, again, this is only on the admission assessment. And you would check all that apply. So if somebody, let's say, possibly used a manual wheelchair for short distances, they used a scooter for longer distances, and let's say they also used a mechanical lift. You would check all 3, or obviously you can check only one if only one is relevant, and if none of these are relevant, the person, let's say, was ambulatory and did not use any of these mobility devices prior to the current event, you would check Z, which is none of the above. So next, I want to move to the next kind of group of items. That's the self-care items. And so these are the items that start with GG0130. And again, if you look to your data set, on the admission assessment, you will see what you see on this particular slide. So in the first column 1, it's called performance, admission performance. You'll see that the admission also has column 2, which is the discharge goal. On the discharge assessment, you'll only see the discharge performance. Again, the goal only applies to the admission assessment. On the left side of the page and on the left side of the slide, you see the coding, and we'll go through that in just a few minutes because that's really important. And on the right side, you see the definitions of the items. And so we'll be covering those as we go through the examples also. So function's really important. Many patients who are admitted obviously have self-care limitations, and they may be at risk for further decline. In terms of the steps for the assessment, the ideal way to gather this information is by observing the patient, but certainly patients who, let's say, are maybe have had a successful stay and they are perhaps going home and the person is able to self-report accurately in some instances on some of these items, certainly that is an acceptable piece of information to consider. Observation is the ideal, but self-report from patient and even family is certainly acceptable to complement. Direct care staff can also provide a lot of excellent information to help with scoring, and some of the examples that we have in the training manual and some of the examples that I have that I'll go over with you will also demonstrate how to gather that information through an interview. There is a 3-day assessment period, so we know that when a patient is first admitted, it may be that you as the clinical staff are kind of getting used to this patient's abilities. If they're, let's say, when we get to eating, you want to be sure that they're safe. You want to be sure that they're doing something that you'll be able to score and again is safe. And so the assessment, it might be on the second day that you really get very comfortable with the patient's functional ability in terms of their usual performance. It's probably more relevant in the mobility area where transfers, if somebody's transferring or starting to walk, that you may be a little bit more tentative and be providing extra help just to be sure that you know that the person's not going to fall or something. So the intent, though, is with these items for both self-care and mobility is to get a good assessment of the person's ability at the time of admission. We give you 3 days so that you can get a good, comfortable feel for what that person's abilities are. The person should be allowed to perform the activities as independently as possible as long as they're safe. So if you have, let's say, a nursing assistant, certified nurse's aide who wants to help the patient with everything, that's not really an assessment because you're not giving the patient an opportunity to perform the activity as independently as possible. And so we do want the scores to reflect what the person has the ability to do. We do not want you to score what the person did once, unexpectedly, but we want kind of their usual status at the time of admission. The third point here is that if a helper assistance is required because of the patient's performance being unsafe or of poor quality, score according to the amount of assistance. So for example, if you have for eating a patient who has a swallowing problem, and so they could theoretically eat, but it would be unsafe because they're just eating so fast and they have the swallowing problem, and you'd be very concerned about some aspiration or some choking. And so somebody actually sits with them, a helper, and it could be a family member, it could be any staff person, but somebody sits with them and basically cues them to slow down. You would say, for this particular person, that they would be scored based on the amount of assistance provided, or in this case, the type of assistance provided, which is the cueing, the supervision, and so that would be the score. So again, even though that person theoretically could eat by themselves, the fact that you need to provide safe care, somebody will be with that person, and that is the score that you're going to report for that particular patient. The activities can be completed with or without assistive devices. If the person uses devices, then they should be assessed using that device. If they do not use a device, you score them obviously without a device. If the patient's self-care performance varies over the assessment period, so I mentioned before the assessment period is 3 days. If the patient's status varies over that time, because as I said, maybe the staff are kind of getting used to the person's abilities, or maybe it's the weekend and things are just, there's not time to maybe complete an assessment because they came in, I don't know, late on a Friday night, and so nobody really got a chance to see their ability to eat. So we want you to report, again, their status at the time of admission, and it should reflect their usual status. And so if there's fluctuation during the 3-day assessment, it wouldn't be the worst, it wouldn't be the best, but it would be what's usual for that individual. We often get questions about who can assess the items, and this set of items is very interdisciplinary, so there's not a list of clinicians who cannot assess, but it is an assessment, and so you need to follow facility, federal, and state requirements in terms of who can do assessments. Certainly, physical therapists, occupational therapists, speech language pathologists, nurses are typical staff involved in the assessment of function items. So refer to your facility, federal, and state policies and procedures to determine which LTAC staff may be able to complete an assessment. So in terms of the coding instructions, as I mentioned at the beginning, or near the beginning, the items in the self-care area in terms of performance are assessed at admission, and they are assessed again at discharge. The coding definitions, the coding levels are exactly the same at those 2 points in time. So I'll be covering those together. In terms of the scoring scale, I'll go through this several times. I'll go through it for self-care, and I'll also go through it again with mobility. If you have questions, please do write them down on the your index cards, and we'll be happy to answer questions as we go through, and if we have time at the end of the day today. So the rating scale is a 6-point scale, and again, if you have the assessment, it would be really great if you had it in front of you. You can actually look at either the admission or discharge. So the 6-level scale starts off with level 6 being independent, and independent means that the patient completes the activity by him or herself with no assistance from a helper. And no assistance means no supervision, no cueing, no physical help. Level 5, which is the second score down, is that reported when the patient requires only setup or cleanup assistance. Setup or cleanup assistance means that the patient completes the activity, the helper assists only with setting up the activity but doesn't actually help with the activity. So when we go through eating, an example might be that somebody helps to open containers for the person or cut up meat. But then after that's done, the helper can leave, and then the patient is able to eat by themselves. Level 4, the person requires supervision or touching assistance. So level 4, as defined on your form, is that the helper provides verbal cueing or touching, steadying assistance as patient completes activity. Assistance may be provided throughout the activity or intermittently. At level 3, that's when there's actually some physical lifting assistance that's happening. And so at level 3, which is called partial or moderate assistance, at this level, the helper does less than half of the effort. So the patient is doing more than half of the effort, but as it's defined on the data set, the helper does less than half of the effort. The helper lifts, holds, or supports the trunk or limb, but provides less than half of the effort. At level 2, the patient is needing substantial or maximal assistance. So at level 2, as defined on the data set, the helper does more than half of the effort. The helper is lifting, holds the trunk or limbs, and provides more than half of the effort. And then level 1 is called dependent, and in this instance, the helper does all of the effort. The patient does none of the effort to complete the activity, or the assistance of 2 or more people is required in order for the activity to occur. So there's significant staff assistance required if there's 2 or more staff, and so that is always coded as level 1. It could be that one person is physically helping, the second person is maybe, for one of the walking items, is pushing a wheelchair behind. If 2 people are needed, the score is a level 1. So I wanted to help you in terms of thinking through coding. So maybe this will help when you're starting to go through the examples. And so these are kind of some key questions to help you think through how to to code patients, and hopefully this will help as you do the training at your facility through this Train the Trainer program. So the first question that you would start off with is, does the patient need assistance to complete the self-care activity? So if we're talking about eating, it would be, does the person need assistance to complete eating? And when I say assistance, again, I want to reinforce that this could be physical assistance, it could be verbal or nonverbal cueing, it could be setup or cleanup assistance, it could be supervision. If the answer is no, then the code would be independent, level 6. If the answer is yes, then we're going to go down to the next question right below. The second question being, does the patient need only setup or cleanup assistance? If the answer is yes, then the code is 5, setup or cleanup. If the answer is no, then we will go down to the next question, which is on the next slide. So in this instance, the question is, does the patient need only verbal, nonverbal cueing, or steadying, touching assistance, supervision? If the answer is yes, then the code is 4, supervision or touching assistance. If the answer is no, then we're going to go to the next question. Does the person need lifting assistance or trunk support? And in this instance, the helper is providing less than half of the effort. If that is accurate, then the code would be 3, which is partial moderate assistance. If the answer is no on this question, then we go down to the next one. Does the patient need lifting assistance, trunk support, with the helper providing more than half of the effort? If the answer is yes to this question, then the score will be 2, substantial maximal assistance. If the answer is no, then we go to our last question. Does the helper provide all of the effort to complete the activity? If the answer is yes, then the code will be 1. So I want to emphasize, all is in italics and bolded here. I think it's in all caps on the data set. Basically, if the patient does anything to contribute, they will go up to a score of 2. Somebody who is scored a 1 is totally dependent. The staff are doing everything, or 2 helpers are needed for the patient to perform the activity. We recognize that certainly some patients may be too ill, or in some cases may refuse to do an activity, or it may be that some items are not applicable. Therefore, there are 3 codes to report that type of information. The first code is 07, patient refused, and this is used if the patient refuses to do the activity. So this potentially could be under mobility with walking where the person doesn't want to get out of bed during the assessment period. Code 9 is not applicable, and that is reported if the patient did not perform the activity prior to the current illness, exacerbation, or injury. Code 88 will probably be used most frequently of these codes in the LTAC setting, and this is used to indicate that the activity was not attempted due to the medical condition of the patient or safety concerns. Some examples, in the area of self-care. So let's say with eating, you have a patient who has a very severe swallowing problem. They get fed, let's say, through a G-tube. Then the eating would be coded as 88. Eating by mouth did not occur, and the definition of eating is very specifically focused on eating by mouth. So administration of G-tube would not count as eating. And so, again, the person does not eat by mouth, they would be coded 88. If you had a patient who, let's say, had a swallowing problem, but it wasn't severe, so in this instance, let's say the person was eating by mouth, but it was just a little bit, they got most of their nutrition through a G-tube, they are eating by mouth, you would record their ability to eat, let's say it's once a day, I don't know. So you would code what they did to eat by mouth, and then obviously the G-tube feeding information would be in a separate section of the medical record reported. So some coding tips. So in terms of who will actually be recording the information in the LTAC Care data set, that person would be reviewing documentation in the medical record. They may be talking to direct care staff if the information needs to be clarified. It may be that in talking to the staff that you need to ask some probing questions, and we have some examples of that. The fourth bullet highlights that it is ideal that the patient is being observed as they perform the activity by the person completing the data set. One thing to note of caution is to make sure that you're considering the entire definition of the item. So when we get to mobility, there's an item about rolling left to right. And so both of those components are important for that particular item. You record the person's actual ability to perform each activity. And so you might say, well, if the person didn't have the swallowing problem and, we did this and, they slowed down, they would be independent. Well, we want to score what actually happens, not what they have the capacity to do, but what is actually going on and the amount of assistance provided at that point in time. The score should be based on the amount of assistance and effort provided. So I think I've talked about that a little bit already, and we'll reinforce it as we go through the examples. The activities can be completed with or without devices, whatever is the person's usual way of performing the activity. So I want to get into the actual items now. So we'll start off by talking about eating. So again, if you pull out your data set, it would be great if you had that right in front of you so you can look at the item. There's a total of 4 self-care items on this data set, and there are 4 items because that was the number of items that were required for the quality measures that are part of the LTAC quality reporting program. So eating is defined as the ability to use utensils to bring food to the mouth and swallow food once the meal is presented on a table or tray, and it includes modified food consistency if that's relevant for the patient. So I have some examples, and I think maybe because this section is a little bit more interdisciplinary in many facilities, what I'll ask is maybe that I'll go through the scenario. You should have that if you have printed out the slides. And I'd like you to look at the data set and then as a table talk through what you think are the right responses, and then we'll whoever is a designated table representative can hold up the number of the score, and I'll see how people do. So the first example is Miss S has multiple sclerosis affecting her endurance and strength. Miss S prefers to feed herself as much as she is capable. After eating 3/4 of her meal by herself, Miss S usually becomes extremely fatigued and requests assistance from a certified nursing assistant. So the certified nursing assistant feeds the remainder of the meal to Miss S. So how would you code eating? So, okay, I see 3s, okay. All right, great. So that is the right response. Eating would be coded 3, partial, moderate assistance. And the rationale is that in this case, the helper is a certified nursing assistant, and that person provides less than half of the effort. The patient performs more than half of the effort. The way that the data set is set up, it talks about a helper. The helper can be anybody. It can be a certified nursing assistant. It can be a family member. If, let's say, the family member is there all the time and wants to help the person with all their meals, it's still scored the same way. Second example for eating. Mr. R is unable to eat by mouth due to his medical condition. He receives nutrition through a gastrostomy tube, a G-tube, which is administered by the nurses. How do you code this item, eating? Okay, I see purples out there. I see a 1. Okay, 88. Okay, correct. The correct response is 88. It was not attempted due to medical condition or safety concerns. The patient does not eat by mouth at this time. This item includes only eating. Assistance with tube feedings is not coded as part of the eating item. I do want to highlight that you can certainly say, let's say on admission, the person, let's say has a G-tube and they're coded an 88 on admission, and let's say by discharge they're doing a lot better, they've gotten to the point that they have less of an issue with the swallowing, and so maybe they are eating, and you can certainly put a code by discharge. So don't be concerned that the person was not coded on admission, but they are coded at discharge. Hopefully, patients have enough improvement in many cases that there will be those circumstances. Okay, the next item is oral hygiene. So oral hygiene includes the ability to use suitable items to clean teeth and dentures if applicable. The ability to remove and replace dentures from and to the mouth and manage the equipment for soaking and rinsing the dentures if that's what the person does. So I should mention, I know on other data sets there are personal hygiene items, and it includes a broader range of activities. In this case, we're only focused on one activity, which is oral hygiene. Hopefully this is one of the more feasible types of activities, because oral hygiene is such an important activity. So even for patients who have very severe conditions as they're admitted, somebody would be doing some type of oral hygiene, even if it's swabs. So the first coding example is about Mrs. F. Mrs. F brushes her teeth while sitting on the side of the bed. The certified nursing assistant gathers her toothbrush, toothpaste, water, and an empty cup and puts that on the bedside table for her before leaving the room. Mrs. F is finished brushing her teeth, which she does without any help. The certified nursing assistant returns to gather her items and dispose of the waste. So maybe this is somebody being discharged, and how would you code? Okay, I see some 5s out there. I agree with that. Okay, so the correct response is indeed 5. Oral hygiene would be coded 5 setup or cleanup assistance. The rationale being that the helper provides setup and cleanup assistance. The patient brushes her teeth without any help. Have another example. In this case, Mr. W does not have any teeth, and his dentures no longer fit his gums. So oral hygiene happens a different way for him. So Mr. W begins to brush his upper gums with the helper. After the helper applies toothpaste to his toothbrush, he brushes his upper gums, but he cannot finish due to fatigue. The helper completes the activity of oral hygiene by finishing up by doing his back upper gums, as well as the entire lower gums for him. So, you know, he does need help. So you have to think through who's providing more of the effort. Okay, I see some 3s and some 2s. Okay, so in this case, the correct response is 2. Just maybe to reinforce that the patient did one part of the top, so the helper did the other part of the top, plus the helper did all of the bottom gums. And so in that instance, we felt that the patient was doing less than half of the effort. Therefore, this particular example was coded a level 2. So I hope that makes sense. Okay, got another example here, but in this instance, the clinician is needing to complete the data set but hasn't actually observed the patient, and so they're relying on staff, and so maybe one piece of information is coming from a certified nursing assistant. And so the nurse asks, does Mrs. K help with brushing her teeth? And the response is, she can help clean her teeth. And so that's really not enough to score, and so there's a follow-up question from the nurse saying, how much help does she need to brush her teeth? And so the certified nursing assistant says, she usually gets tired after starting to brush her upper teeth. I have to brush most of her teeth. So again, you're in a situation where you need to think, who's doing more of the effort? Is it the patient or the helper? So the correct response here is 2, which I saw quite a few orange. Okay, great. So yes, the certified nursing assistant provides more than half of the effort to complete Mrs. K's oral hygiene. The next activity that we'll be talking about is toileting hygiene. And toileting hygiene is defined as the ability to maintain perineal hygiene, adjust clothes before and after using the toilet, commode, bedpan, or urinal. If managing an ostomy, it would include wiping the opening, but not managing the equipment. So some examples here. So again, if you look at your data set with the items, Mrs. J uses a bedside commode. The certified nursing assistants provide steadying, also known as touching assistance, as Mrs. J pulls down her underwear before sitting down on the toilet. When Mrs. J is finished voiding or having a bowel movement, the certified nursing assistant provides steadying assistance as Mrs. J wipes her perineal area and pulls up her underwear without assistance. What do you think about coding that? So there was touching assistance when she was pulling down her underwear. She the helper provided steadying assistance during the cleansing wiping, and then also as the patient was pulling up her underwear. Okay, I see 4s and 3s. Okay. The correct response in this case is a level 4. The patient required the touching assistance, and so that's part of the definition of level 4. So the helper provided steadying, touching assistance as the patient completed toileting hygiene. So there's really 3 activities within the toileting hygiene. It does not include getting to and from the bathroom. So I think in the training manuals, you'll see some examples where the patient, let's say, was walked to the bathroom. So theoretically it could be, it takes 2 people to help the person walk to the bathroom, but then when they're in the bathroom, let's say it was just steadying assistance, the score would be unchanged for toileting, because toileting only basically are the activities that occur in the bathroom. It's basically pulling the underwear down if the person's wearing underwear, pants potentially if they're wearing pants, the cleansing, and pulling the underwear back up. So it's kind of 3 main activities. So don't worry about what type of commode the person uses. If it's in the bathroom, if they have to walk to the bathroom, that's not considered in the scoring. So just kind of watch out for those examples if you're trying to teach this particular item to your staff. Okay, we have another example. This one's a little bit longer. Ms. Q has a progressive neurologic disease that affects her fine and gross motor coordination, balance, and activity intolerance. She wears a hospital gown and underwear during the day. Ms. Q uses a bedside commode. She steadies herself with one hand and tries to pull down her underwear, but she has problems, and so she needs assistance from the helper to complete this activity due to her coordination impairment. So essentially, in this case, the helper is pulling down her pants. After voiding, Ms. Q wipes her perineal area without assistance while sitting on the commode. When Ms. Q has a bowel movement, the certified nursing assistant performs perianal hygiene. Ms. Q is too fatigued at this point and requires full assistance to pull up her underwear. So the helper is basically pulling down her underwear. The helper is pulling up the underwear after the bathroom voiding or bowel movement. In some cases, she cleanses if it's voiding, but the helper cleanses if it's a bowel movement. So the patient is doing some activity, but would you say the patient is doing more or less than the effort? Okay. see a lot of twos out there, which would mean that the helper is providing more than half of the effort, and that is correct. Toileting hygiene would be coded 2, substantial maximal assistance. The helper provided more than half of the effort, as you correctly indicated. Okay, we have another scenario that's an interview. So again, in this case, it may be that the nurse is supplementing information to find out what happened over a weekend. And so in this case, the nurse says to the certified nursing assistant, "I understand Ms. J wears a hospital gown and underwear. Describe to me how Ms. J usually does her toileting hygiene. Is she able to manage her clothing before and after going to the bathroom, and is she able to wipe herself?" So again, the 3 main activities that we talked about for toileting hygiene: pants down, cleansing, and pants underwear back up. So the certified nursing assistant in this instance gives us the information. She needs help getting to the bathroom and some help to wipe herself. So that's really not enough to help us. It's getting us started in terms of scoring, so we know that she does need some help in terms of wiping. As I said before, getting to and from the bathroom is information that's obviously relevant for the nurse, but it's not actually going to be taken into consideration for the actual scoring of this item. There are separate items related to walking that we'll get to when we talk about the mobility section. So the certified nursing assistant is asked some more information. So the nurse says she needs assistance to complete her perineal hygiene. Does she manage her underwear before and after using the toilet without you giving her physical assistance cues or setting her up with toilet paper? And the certified nursing assistant replies, "No, I have to physically hold onto her gait belt and support her as I pull down her underwear. She wipes her perineal area, and then I pull up her underwear afterwards." So again, the nurse had to ask very specific questions to figure out that the certified nursing assistant is definitely providing some support because there's a gait belt that the CNA is holding on to. And then the CNA says she's pulling down her underwear, she wipes, and she helps her pull up her underwear. So how would you score this example? Sorry. Okay, so I see a lot of 2s out there. That's correct. So toileting hygiene would be coded 2. The patient definitely is doing a little bit to help. The helper provided more than half of the effort, however. Okay, we're getting to the last item in the area of self-care, and that is wash upper body. Given that the patients are often very ill, washing the entire body is not maybe feasible in many circumstances. So this particular item is focused on just washing the upper body. It is defined as the ability to wash, rinse, and dry the face, hands, chest, and arms while sitting on the side of the bed or in a chair. Could be in the bathroom, could be in the room in a private area. It really doesn't matter. So getting to and from the location is not considered in the scoring. That'll be picked up under the walking area, mobility section. So we have another example. In this particular example, Mrs. L has severe rheumatoid arthritis and peripheral vascular disease that affects her hands with joint pain, weakness, numbness, and tingling. Mrs. L uses a wash mitt to wash her upper arms and part of her chest. The certified nursing assistant helps to wash and rinse her face and part of her chest. Mrs. L rinses her arms and chest after the certified nursing assistant places a rinsed mitt in her hand. She soaks her hands in soapy water and rinses them under the faucet that is set up for her use. Mrs. L slowly dries herself with a towel. So I'll let you spend a little bit of time on this because there's a lot of information to absorb, but basically think through who's doing what activities. Some people are quick. I'll give everybody a moment though. Okay, what do you think? Okay, I see some 3s, and that would be correct. So in this instance, the patient was doing more than half of the effort, and so the correct code is 3. So the helper, which is the perspective of the data set, the helper provided less than half of the effort to complete the activity. Okay, another example. Mr. D has ALS and has upper extremity weakness with uncontrollable twitching. Mr. D is very motivated to perform the activity of washing his upper body. The nurse always offers to work with Mr. T hand over hand in the activity to manage his twitching, while he washes, rinses, and dries his face, hands, arms, and chest. Mr. D requires the nurse to move his hands and contain his tremors during the activity. So this is kind of a hard scenario to put in one slide so that you can read the type, but basically in this instance, the helper is basically doing a lot of the effort, and so we do clarify that the helper is basically doing the work. It's just with the patient using whatever the patient is able to do to help. So the person actually, the patient, Mr. D in this case, is definitely doing something, so he should get credit for that, but the helper is doing more than half of the effort. So I see some 2s out there. Okay, and I do agree with that. Washing upper body would be coded 2, substantial assistance. The helper provided more than half of the effort. Certainly, it would be reasonable if a patient did not have severe twitching. Let's say it was a patient with another condition and the helper just provided just a little bit of help. It could have been a completely different code. But in this instance, it said that the helper was doing more than half of the effort. Therefore, that was coded a level 2. Okay, we have another example here in terms of the wash upper body item. And again, it's an interview. So the nurse says, describe how Mr. C usually washes his upper body. Specifically, does he wash, rinse, and dry his face, hands, chest, and arms while sitting in a chair or bed? And so the CNA responds, he has to sit in his bed because he's too weak in the morning to get to the sink, and I have to help him do most of it. So we have an inkling of what the score might be, but the nurse does ask for some clarification. So in this instance, the nurse says, what can Mr. C complete for himself when washing, rinsing, and drying his upper body? Does he need instructions, safety reminders, setup, or physical help? The CNA responds, I have to give him a basin of water, washcloth, and open his soap container, lather his wash rag, and place it in his hand. I encourage him to wash his arms, but he always gets tired after washing one of his arms. I then do all of the remaining washing, rinsing, and drying of his upper body. I've tried giving him a little rest break before asking him to continue washing himself, but he then complains of feeling cold and wants me to finish washing him. After washing his upper body, I have to clean up the wash basin, washcloth, and soap. Okay, so I see a fair number of 2s out there. Others? Okay, what do you think over here? There's nobody holding up signs. I'm gonna pick on you guys over here. What do you think? Okay, thank you. Number 2 is correct. Okay, so wash upper body would be coded 2, substantial maximal assistance. The helper provided more than half of the effort to complete the activity of washing. Okay, so next I want to move to talking about the other, the last type of item in section GG related to self-care function, and that is the self-care discharge goal. So if you look at the admission data set, you will see that there's 2 columns, as I mentioned before. The first column, we've covered the basics on that in terms of the admission performance, and now we're going to the discharge goal. This is only included on the admission assessment. So in terms of coding tips, the really important point here is that you are only allowed to code using the 6-point scale. So for a goal, to be accepted by the systems, it has to be 1 through 6. You will not be allowed to enter a 7, 9, or 88. And that's because it probably doesn't make sense to say that the goal is the patient would be refusing to perform an activity by discharge. You do not need to put goals for every item. We'll cover that in a few minutes, in a few slides. Hopefully there will be an activity that you'll be able to score 1 through 6. And we'll go through some different examples in just a few minutes, but again, only code dependent through independent for the goals. Licensed clinicians can establish a patient's discharge goals at the time of admission based on the admission assessment, discussions with the patient and family, professional judgment, as well as professional standards of practice. Goals should be established as part of the patient's care plan. So one of the reasons that the goal section is on the data set is that one of the quality measures, actually 2 of the quality measures that are part of the LTAC quality reporting program include the assessment of self-care and mobility activities and the establishment of at least one goal that's incorporated into the care plan. So that's why these items are on the data set. Certainly, a facility can look for their patients to see what patients' scores were when they were admitted, let's say for eating, goals that were set for the patient on admission as discharge goals, and then when the patient's discharged, you can look to see what percentage of patients actually achieved the goals that were set. That's a really helpful thing to do and something that's done in many settings. That is not, I should clarify, that's not something that CMS is doing as part of the quality measure, but the process of reporting the discharge goal for at least one self-care or mobility item is what's required as part of the quality measure. So just to reinforce that, on the next slide, 53, you'll see that there are actually 2 quality measures that are relevant here. So the first one is the percent of long-term care hospital patients with an admission and discharge functional assessment and a care plan that addresses function. And the documentation that the care plan includes function is documentation of a goal on the data set. The Mary Pratt mentioned this morning the IMPACT Act. The IMPACT Act required that CMS had cross-setting measures, and so this past year CMS also adopted an application of the LTAC process measure as part of the quality reporting program. For you, the relevant point is just at the bottom in terms of what's in bold. A minimum of 1 self-care or mobility function goal must be coded on the data set for each patient. And that will cover you for both of these quality measures. So again, just to reinforce that, report 1 discharge goal on the admission assessment per patient in order to meet the requirements of this quality measure. Okay, I want to talk through some examples because I anticipate there'll be questions about this. In an LTAC setting, there may be patients who are expected to have functional improvement, but not all patients. And so it may be that you have a goal for one patient where the admission score is let's say, a 3, and the expectation is that the person will improve to a 4 or maybe higher. So we have an example here where functional improvement is expected, and so it is an example of washing the upper body. Mr. M prefers to wash himself rather than depending on helpers or his wife. The clinician assesses Mr. M's admission performance for washing the upper body and codes Mr. M's performance as substantial assistance. So that's a code of 2. The clinician thinks through Mr. M's condition and determines, okay, I'm thinking about his prior functioning, I'm thinking about his conditions, his comorbidities, his expected treatments, his motivation to improve, his anticipated length of stay, as well as the prognosis. And the clinician discusses the goals with the patient and family, and they anticipate that Mr. M will require a helper to do less than half of the effort by discharge. Therefore, the clinician codes the discharge goal as level 3. So again, the clinician is using professional judgment, discussing the treatment plan and goals with the patient and family, and comes to the determination in this instance, functional improvement is reasonable to consider, and the discharge goal therefore is higher. The second example is an example where the discharge goal is coded the same as the admission performance. So even though we call these goals, and many of you may always think, well, are you expecting functional improvement for all patients? The answer is no. A goal may be that the performance is maintained. And so we have an example here for oral hygiene, where the clinician anticipates the patient will have the same level of function for oral hygiene at admission discharge. The patient at the beginning of the stay, so this Mrs. E has severe arthritis, Parkinson's, diabetic neuropathy, and renal failure. These conditions result in multiple impairments. So on admission, the clinician observes Mrs. E and discusses usual performance with clinicians, caregivers, and family to determine the necessary interventions for the therapy care plan. The clinician codes Mrs. E's admission performance as level 2, substantial maximal assistance on admission. Due to Mrs. E's progressive and degenerative condition, the clinician and patient feel that while Mrs. E is not expected to gain function in terms of oral hygiene, maintaining function at this time is desirable and achievable as a discharge goal. Therefore, the clinician codes the discharge goal as level 2, substantial maximal assistance. And a third instance, sometimes a patient is admitted and has a condition that will get worse, and so part of the treatment may be to slow down the decline as much as possible, but there still may be decline expected. Therefore, there are potential situations where the discharge goal is lower than the admission goal. The admission score, sorry, I misspoke there. So let me say it again. The discharge goal is lower than the admission score. So we have an example with toileting hygiene here. Mr. T's participation in skilled therapy is expected to slow down the pace of her anticipated functional deterioration. The patient's discharge goal code will be lower than the admission performance code. So on admission, it just says that she has a progressive neurologic illness. She prefers to use a bedside commode on admission rather than have using incontinence undergarments. The clinician codes the admission performance as level 3, partial moderate assistance. By discharge, it is expected that Mrs. T will need assistance with toileting hygiene and that the helper will perform more than half of the effort. So in terms of coding, the discharge goal in this instance, again, would be lower as a level 2. So next, I want to move to mobility. And so this is slide 60. So consistent with the self-care items that I covered before, on the admission assessment, you will see that there is a column for performance, admission performance on the admission form and discharge performance on the discharge form. The second column has a discharge goal on the admission form. There is no second column for a goal on the discharge because you only set goals for during the stay on the admission form. Also, I did want to highlight that on the mobility section, there are some what we call gateway questions or screening questions. So we've put those off to the side because you do not use the 6-level scoring scale for those items. They have their own coding scale, coding responses. And so we'll be covering those in a little bit. But basically, the first column for mobility uses the 6-level rating scale that we talked about with self-care. There are items related to walking, wheelchair use, and it may be that some of these items are not applicable or that it's unsafe for somebody to perform some of these activities. And so again, you can use for the admission or discharge the code 7 and 88 to indicate that the patient does not attempt the activity. The discharge goals can only be coded 1 through 6, and then the third column you see on the form, they have their own codes, so we'll go through those. So as I mentioned earlier, the LTAC patients often are admitted with mobility limitations, and as all of us learned through our clinical training, immobility has hazards, and so patients are very at risk for having further decline as well as complications from lack of mobility, and so that's why the function items are included on the data set. In terms of the steps for the assessment, it's the same as self-care. It is ideal that patients would be observed performing these mobility activities by one of the clinicians, whether it be a physical therapist, an occupational therapist, or a nurse potentially. The patient's self-report can certainly be taken into consideration, as well as reports from the clinician, the direct care staff, as well as family members if the family members are present and assisting with any care. The assessment period is 3 days. Again, that's consistent with the self-care activities. Also consistent with the self-care activities, patients should be allowed to be as independently, perform the activities as independently as possible. You're not really doing assessment if you just go in and help the person do an activity. So allow the patient to be performing the activity as independently as possible for all of the items in the self-care and mobility areas. If a helper provides if assistance is required from a helper due to safety or poor quality, let's say in terms of walking, you score what assistance is provided. And I think I talked about this under the self-care activity. So let's say somebody really could walk 10 feet, but it's pretty scary to watch them, and it's not something that you would have them do. They could do it, but it's not safe, and so you're going to be there with them in the LTAC setting. And so you would actually score based on the amount of assistance that was given in order to help them walk safely. So it might be that you're walking with them with a gait belt in order for the patient to be safely walking. So number 4 on slide 63, we're getting into, again, some of the same issues for assessment that we talked about under self-care, and that is that the activities may be completed with or without devices, whatever the person uses, assess them with that device. If they typically use a device at home, but let's say it's broken or it's not available, you assess them on whatever they're using at that point in time of the assessment, whether it be admission or discharge. If the patient's mobility performance varies across the 3-day assessment period, again, we're interested in the person's status on admission. What is their ability as they are basically entering your hospital? And then for discharge, what is their status as they leave your facility? And if somebody's admitted on the weekend and the staff maybe are providing a lot of help because they're just not sure, let's say, how well the person can transfer in and out of bed or in and out of their wheelchair, an assessment needs to be done by a professional in order to determine the person's ability. So it's not the most dependent episode or the most independent episode if there is variation, but their usual status. Again, consistent with what I mentioned under self-care, CMS is not telling you that certain clinicians can or cannot do assessment. You need to follow the facility, federal, and state requirements in terms of who can perform an assessment. The coding is done on admission and the planned discharge. And actually, this is probably a good opportunity to explain that there's 4 data sets for the LTAC Care data set system. So we talked about admission. At discharge, there's actually 3 different types of assessments. So the planned discharge, which is mentioned on this slide, and function can be assessed when there's a planned discharge. In the situation, which unfortunately sometimes happens, where somebody has a medical emergency and there's an unplanned discharge, we want you to worry about the medical emergency. Functional status can be worried about later, and so there's actually not self-care or mobility items on the unplanned assessment form. And that's because it's hard to assess somebody's function when they're in the middle of a medical emergency. Also, in the case if a patient passes away, there's no discharge function reported. So on admission, you're completing it for everybody, self-care and mobility. At discharge, if somebody has a planned discharge, you are filling out the planned discharge form. All of the self-care mobility items are on that data set. If the patient leaves AMA and you're filling out the unplanned discharge form, or again, if there's a medical emergency and you're filling out the unplanned discharge form, you're not able to enter function data because it's not necessary and it's not required as part of the quality measure calculation. Okay, so the next issue is the rating scale. So we've gone over the rating scale. It's 6 through 1. And again, I have the coding questions here. I guess I'll go through them again just to reinforce. So you start off with the mobility items with the same questions. Does the patient need assistance to complete the mobility activities? And assistance includes physical assistance, verbal, nonverbal, cueing, supervision, cleanup, and setup assistance. So if the answer is no, the person does not need help, then you code a 6. If the answer is yes, we're going to go to the next question, which is, does the patient need only setup or cleanup assistance? If the answer is yes, the code is a 5, setup or cleanup assistance. If the answer is no, then we're going to go to the next question on the next slide, which is, does the patient need only verbal, nonverbal cueing, or steadying, touching, assistance, supervision? If the answer is yes, the code is 4, supervision or touching assistance. If the answer is no, then we go down to the next question at the bottom of the slide. Does the patient need lifting assistance or trunk support with the helper providing less than half of the effort? If the answer is yes, the code is 3, partial moderate assistance. If the answer is no, then we go to the next slide with the next question. Does the patient need lifting assistance or trunk support with the helper providing more than half of the effort? If the answer is yes, the score will be 2. And if the answer is no, we'll go to that last question with the helper providing all of the effort to complete the activity. If the answer is yes, then the code is a 1. As with the self-care activities, it is actually more likely that you might have 2 people helping a patient with one activity. If you have 2 or more helpers, it could be family and staff combination, but 2 or more helpers means that the patient will be scored a level 1 for an activity. The codes are the same that we talked about for self-care. If the patient does not attempt the activity, we would like to know why the activity was not attempted. Code 7 would indicate that the patient refused. Code 9 indicates that the person is not applicable. Code 88 means that the activity was not attempted due to a medical condition or safety concern. So coding tips are the same as what we talked about with self-care. So review the documentation. There is a 3-day assessment period. If you need to supplement that information to find out more information, talk with the direct care staff. Certainly probing questions are appropriate in many instances to get all of the detailed information you need in order to score. Observe the patient if at all possible. in terms of if you're the person coding, that's ideal. Be specific in terms of the actual definition. So think about the entire definition when you're coding. Record the person's actual ability. So again, if you thought, well, if the room was bigger and I moved the bed this way and the person had weakness on the other side, they'd be able to do it. That doesn't count. You code what actually happens, not what could be or would be, but what actually happens. It's just too easy to make everybody independent if everybody, if you start making those kind of what ifs. So again, actual performance. The score should be based on the amount of assistance or effort provided, and activities can be performed with or without assistive devices, whatever is appropriate for the patient. So these are the items included in the mobility section: roll left and right, sit to lying, lying to sit on side of bed, sit to stand, chair to bed chair transfer, and toilet transfer. There are some walking items that we'll get to in a little bit, but this is the first group of items. Again, these are coded on admission and discharge. So we're actually just more than halfway past this section. This is a 2-hour session. There's a lot of information here. So for this particular item, I'm going to maybe change things up a little bit. So I'm going to read the example, and if you're willing, if we could do maybe everybody stand up, and I'll go through who coded what, and I'll go through maybe the wrong codes, and we'll see who's left standing. So it's kind of like stand-up bingo. So I know most of you are used to probably running around all day and not used to sitting down, so I want to maybe give you a little bit more energy before we keep going here. So roll left to right. Mr. R has a history of skin breakdown. The nurse instructs him to turn onto his right side, providing step-by-step instructions to use the bed rail, bend his left leg, and then roll onto his right side. The patient attempts to roll with the use of the bed rail, but indicates he cannot do the task. The nurse then rolls him onto his right side. Next, the patient is instructed to return to lying on his back, which he successfully completes. Mr. R then requires physical assistance from the nurse to roll onto his left side and to return to lying on his back to complete the activity. All right, so everybody stand up if you don't mind, or put your hands up. Trying to help. Okay, some people are putting up signs. Okay, great. All right, so who thought he was independent or set up? Sit down. Okay, nobody. All right. Who thought maybe he didn't attempt the activity? That doesn't apply, right? So nobody's sitting down. All right. Who thought he was level 3? Sit down. Okay. The correct answer is 2. So everybody's standing. Excellent. You guys know this. You don't need me. Okay. All right. You can sit back down now. Thank you very much. I hope that maybe put a bit of energy. Okay, so you are correct. Code 2 is used for substantial maximal assistance. The nurse provided more than half of the effort for the patient to complete the activity of roll left and right. Okay, the next item that we'll be talking about, or the activity, is sit to lying. Sit to lying is defined as the ability to move from sitting on the side of the bed to lying flat on the bed. And then in this scenario, Mrs. H requires assistance from the nurse to transfer from sitting on the side of the bed to lying flat on the bed because of paralysis on her right side. The helper lifts and positions Mrs. H's right leg. Mrs. H uses her arms to position her upper body. Overall, Mrs. H performs more than half of the effort. So how would you code her? I see some 3s. Okay. All right. Anybody on this side? Okay, 3. Thank you. In the back. So 3 is correct. Sitting to lying would be coded level 3, partial moderate assistance. A helper lifts Mrs. H's right leg and helps her position it as she moves from a seated to a lying position. Mrs. H does more than half of the effort, and so she would be coded a level 3 in this instance. The next example is sit to lie. Mrs. H requires assistance from 2 certified nursing assistants to transfer from sitting at the edge of the bed to lying flat on the bed due to paralysis of her right side, obesity, and she has some cognitive limitations. One of the certified nursing assistants explains that Mrs. H, she explains to Mrs. H each step of the sitting to lying activity. Mrs. H is then fully assisted to get to the lying, from sitting to the lying position on the bed. Mrs. H makes no attempt to assist while asked to perform the incremental steps of the activity. So how would you code her? Yeah. Okay, so I see a lot of white level ones. That's correct. So we don't have a ton of examples today related to level 1, especially for self-care, because in general those situations tend to be easier to score. Usually we've gotten the most questions when there's questions about scoring level 5 through level 2. In general, clinicians have expressed it's a lot easier to score the dependent and the independent, and so that's why we've mainly focused on kind of the middle scores. I know many of your patients may be very dependent in a lot of these activities, and therefore they may be coded level 1 in many instances. And here is one example. Okay, so moving to the next activity, lying to sit on the side of bed, which includes the ability to safely move from lying on the back to sitting on the side of the bed with feet flat on the floor and no back support. So here the example is Ms. P is being treated for sepsis and has multiple infected wounds on her lower extremities. Full assistance from the certified nursing assistants is needed to move Ms. P from the lying position to sitting on the side of the bed because she usually has pain in her lower extremities upon movement. So with all of the activities that we're talking about, it doesn't matter why the person doesn't do it, why the person needs assistance. So it could be very, very severe pain and somebody doesn't perform an activity, it's not attempted, or the person refuses, or the person has paralysis. We've had lots of those examples. So with all of the activities, we're not really worrying why the person can't perform the activity. That will be documented elsewhere in the medical record. In this particular section GG, we're just focused, can the person, or does, I should more appropriately say, does the person perform the activities? If they do, how much help do they need to complete the activity? So again, pain is a legitimate reason why somebody might need assistance. So I saw some ones up there, so that is the correct, thank you, correct code. The helper fully completed the activity of lying to sitting on the side of the bed for the patient. Okay, the next example for lying to sitting on the side of the bed, Mr. B pushes up on the bed to attempt to get himself from a lying to a seated position as the occupational therapist provides much of the lifting assistance necessary for him to sit upright. So at this point, we know it's more than just touching assistance. The occupational therapist provides assistance as Mr. B scoots himself to the edge of the bed and lowers his feet onto the floor. Overall, the occupational therapist performs more than half of the effort. So what score would that be? Okay, I see a lot of orange 2s. That would be correct. So level 2, substantial maximal assistance. I agree. The helper provides lifting assistance, more than half of the effort as the patient moves from lying to sitting. Our next example is sit to stand, and this is defined as the ability to safely come to a standing position from a sitting position. So if a patient is, let's say in a wheelchair, they're not walking, they do not come to a standing position, you would be coding that this activity did not get attempted by the patient. We have an example here. Mr. M has osteoarthritis and is recovering from sepsis. Mr. M transitions from a sitting to a standing position with the steadying, touching assistance of the nurse's hand on Mr. M's trunk. So this is an example of touching assistance. How would you score that? 4. So this is probably somebody being discharged. This is a functional person in terms of they're just needing a little bit of assistance in terms of the transfer. So maybe in this instance, it's a gentleman and he's got an elderly wife, so she would be able to provide this type of assistance at home, whereas if it was lifting or more, it might be difficult for her to do that. And that's in part why we, as part of the scoring scale, differentiate between the steadying, touching assistance at level 4, and then we get into the lifting assistance at level 3 and level 2, because many family members may or may not be able to provide that level of physical assistance in all circumstances. Okay, so level 4 was the correct response that was provided. Excellent. Okay, so we have another interview scenario here. So in this instance, the nurse says to the certified nursing assistant, please describe how Mrs. L usually moves from sitting on the side of the bed or chair to a standing position. Once she's sitting, how does she get to a standing position? So the certified nursing assistant says she needs help to get to a sitting position and then standing. Well, that's not enough. So as you can imagine, we've got a follow-up question from the nurse. I'd like to know how much help she needs for safety, rising up from sitting in the chair or sitting on the bed to get to a standing position. And so the response here, she needs 2 people to assist her to stand up from sitting on the side of the bed or when she is sitting in the chair. So how would you code this? Okay, I see some ones. And what's your rationale? 2 people, excellent. Thank you. So code 1. Mrs. L requires the assistance of 2 helpers to complete the activity. The next activity is chair bed to chair transfer, the ability to safely transfer to and from a bed to another chair or into a wheelchair. In this instance, we have an example. Mrs. F's medical conditions include morbid obesity, diabetes mellitus, and sepsis, and he recently underwent bilateral above-the-knee amputations. Mr. F requires full assistance with transfers from the bed into a wheelchair using a lift device. 2 certified nursing assistants are required for safety when using the device to transfer Mr. F from the bed to the wheelchair. So you probably know this one, right? 1. Okay, that's right. 2 people. They're using a device that requires the assistance of 2 people for safety, and so we know that that's going to be a level 1. Okay, another example. Ms. P has metastatic bone cancer affecting her ability to use her lower and upper extremities during daily activities. Ms. P is motivated to assist with her transfers from the side of the bed to the wheelchair. Ms. P pushes herself up from the bed to begin the transfer while the therapist provides trunk support. Once standing, Ms. P shuffles her feet, turns, and slowly sits down into the wheelchair with the therapist providing trunk support. Overall, the therapist provides less than half of the effort. So there is a fair bit of support happening in terms of trunk, but as the last sentence indicates, the therapist is providing less than half of the effort. So how would you code that? Okay, I see a lot of 3s over here, and 3s, okay, in the back, over there, 3s, okay, great. I agree, partial assistance in this instance. And the rationale being that the helper provided less than half of the effort for the patient to complete the activity of transferring from the bed to another chair. Another item in the mobility section relates to getting on and off the toilet. This is obviously a very important activity that all of us do every day. The ability to safely get on and off a toilet or commode is included in this particular item. So it doesn't actually have to be a toilet in the bathroom, it can be a commode. So we have an example here. Mrs. Y is anxious about getting up to use the bathroom. She asks the certified nursing assistants to stay with her in the bathroom as she gets on and off the toilet. The certified nursing assistant stays with her as requested and provides verbal encouragement and instructions or cues to Mrs. Y. So this is somebody hopefully being discharged who's had a successful stay and has had some functional improvement. What would you say might be her score? Mrs. Y, who is anxious. Okay, I see some 5s and some 4s. The correct response here is actually supervision. So in this case, the certified nursing assistant stayed with her. And so that is the supervision level. And so that's coded a level 4. I think I mentioned this early on, but I will reinforce that supervision can be intermittent or constant. It can be close supervision or distant supervision. I know I see in clinical documentation people differentiate that. We actually don't differentiate close and distant supervision on the coding scale. Either type of supervision would be coded level 4. And I'd also like to just bring up this example scenario. Talks about the patient is anxious, and in this case, the certified nursing assistant decided to stay with the patient, and so we follow that rule, code what actually happens, not what could be, would be, possibly might be. So we coded appropriately that somebody stayed with her. If the staff determined, for whatever reason, and let's say this person was going home. Let's say they were doing really well and the person was anxious and the staff said, no, you're going to be going home alone. We think you're fine. If that was the circumstance, and so nobody stayed, even though the person wanted somebody to, you would code what actually happened. So if nobody stayed, potentially the score would be different. But again, in this instance, somebody stayed, and so the correct score was 4 because of that supervision. So the anxiety of the person isn't what we coded what actually happened. Okay, next example, Mr. H has paraplegia incomplete, as well as pneumonia, and a respiratory problem, COPD. Mr. B prefers to use a bedside commode rather than going into the bathroom when moving his bowels. Due to his severe weakness, a history of falls, and dependent transfer status, 2 certified nursing assistants assist during the toilet transfer. What score? A 1. Okay, I think that message probably got through, right? We've had quite a few examples with that. Okay, so next I want to move to the third column, as I called it. So again, the first column on the admission assessment is for admission performance. The second column is for goals. The third column, we have some gateway questions, and so there's a different scoring scale, and that's why they look different on the data set. It's to cue you to use the rating scale that's provided with that item. So H asks, does the patient walk? And there's actually 3 responses here. So the first response is no. The person does not walk now, and a walking goal is not clinically indicated. So it may be that you have a patient who has a complete spinal cord injury. They do not currently walk. Let's say they use a wheelchair, and it's not expected, perhaps at this point in time, that the person would be walking by discharge, and so in this instance, you would code a 0. If that is the case, then you will see that this question has you skip to the wheelchair section. If the patient is not walking, but it may be possible that the person is walking by discharge, then you would code 1. And 1 is, as on the data set it says, so the question is, does the person walk? So the response for 1 is no, and walking goal is indicated. So let's say this person has had a stroke, they're not currently walking, but the person is expected to be able to walk short distances by the end of the stay, then you would code 1 in this instance. So this is actually important, and I'm sure there will be help desk questions about this one. But basically, this item is set up so that when you're entering data, you're able to enter the correct data. So if you coded 0, that the person was not walking, and a walking goal was not expected for this person at this point in time, then you will skip out all of the walking items in terms of the assessment of performance as well as goals. If you code 1 saying no, the person does not walk now, but there may be a goal, then that will open up the items for you to be able to enter goals for the person. So does that make sense? The third option for this particular item in response to the question, does the person walk, is yes. And in that instance, you would be expected to report an admission assessment, as well as you could report a goal if there were a goal related to walking that you wanted to provide on the data set. You will see that there's 3 distances related to walking. So in some circumstances, you may have patients who are only able to walk short distances. They can maybe get to the bathroom and back. Other patients may be able to walk in the hallway a little bit and make turns around the corner. And you may also, in some cases, have somebody who can walk 150 feet, so they can walk quite far down the corridor or hallway. So we have a few examples here. So we do have examples related to this coding for walking because, again, wanted to reinforce this information with you. So, so for the item, does the person walk? So again, look at your data set. Mr. Z currently does not walk, but a walking goal is indicated. So again, it could be somebody currently in a wheelchair, but the expectation is that they will improve and be able to walk short or long distances. So what would you code, 0, 1, or 2? Okay, I see a lot of 1s, that is correct. And so by coding 1, you're saying no, that the person doesn't walk right now, but they are expected to, and you would be able to, if you chose to report a goal, you'd be able to report that under the 10 feet distance, the 50 feet with 2 turns, or the 150 feet. The rationale for this is the patient does not currently walk, so no admission performance code is entered for the walking items. However, a walking goal is clinically indicated in this circumstance, and walking goals may be coded on the data set. Another example, Ms. Y currently walks with great difficulty due to her progressive neurologic disease. It is not expected that Mrs. Y will continue to walk. So how would you code her? She does walk with great difficulty. Okay, so on admission, she would actually be coded a 2. So again, so on admission, you're just coding, does the person walk? And so if the answer is yes, you would code the 2. If the person doesn't currently walk, it could be either the 0 or the 1. So in this circumstance, it says she walks. She has great difficulty, so she'd definitely be needing assistance. We'll see a code below probably level 4 in this instance. If we were doing the care scoring 6-level scale. But in this instance, she is able to walk, and so she is coded a level 2. And so then you would be able to enter a score for walking 10 feet, walking 50 feet with 2 turns, walking 50 feet. Given that she has great difficulty, you may be using that code 88 for the 150 feet would be my guess. So I hope that makes sense. So we have a couple of examples related to different distances. So in this case, the person is only walking a short distance, 10 feet, which would be, once standing, the ability to walk 10 feet in a room, corridor, or a similar space. So Mrs. C has Parkinson's disease and walks with a walker. The physical therapist must advance the walker for Mrs. C with every step. The physical therapist assists Mrs. C by physically initiating the stepping movement forward, advancing Mrs. C's foot during the activity of walking 10 feet. The assistance provided to Mrs. C is more than half of the effort for her to walk the 10-foot distance. So she is providing some effort, but the therapist is providing a lot of assistance. How would you code? I see a lot of orange 2s. Okay, I agree with that. So level 2 is correct. The helper provides more than half of the effort. Next example is 50 feet with 2 turns, which starts when the person is standing, and so this item, as you would expect, includes the ability to walk 50 feet while making 2 turns as part of that distance. So Mrs. L is unable to bear her full weight on her left leg. As she walks 60 feet down the hall with her crutches and makes 2 turns, her therapist supports her trunk. The therapist provides less than half of the effort. How would you code Mrs. L? Okay, I see some 3s. Okay, I agree, a level 3, partial moderate assistance. The helper provides trunk support as the patient walks more than 50 feet and 2 turns. Next example is walking 150 feet, once standing again. It is the ability to walk at least 150 feet in a similar or a corridor or similar space. So in this particular example, Mr. R has endurance limitations due to heart failure and has only walked about 30 feet during a 3-day assessment period. He has not walked 150 feet or more during the assessment period, including with the physical therapist who has been working with Mr. R. The therapist speculates that Mr. R could walk this distance in the future, but right now, he's not able to. So how would you code? Okay, 88, that's right. I think that's the first time I've had you code 88, but that is correct. In many instances, patients may not be able to walk 150 feet, but you would be coding this as 88 if the person is walking on admission and you haven't been skipped out of this set of items. Okay, so next we get into the wheelchair items. So we have another gateway or screening question here. And so we just ask basically here, does the patient use a wheelchair or scooter? If the answer is no, you code 0. If the answer is yes, you code 1. If the answer is no, the person does not use a wheelchair or scooter, you're going to skip out of all of these items. If you answer yes, there are 4 questions that are to be completed. R, RR1, S, and SS1. So the first one is R, which is wheeling 50 feet with 2 turns. So this begins once the person is seated in the wheelchair, so this is very consistent with the starting from a standing position for the walking item, so we don't worry about the transfer, that's coded elsewhere. So once the person is in a seated position, what is their ability and how much help do they need to wheel at least 50 feet to make 2 turns? I do want to emphasize that we want an assessment, so if somebody is just I don't know, needing some kind of test or wants to go down to the cafeteria and somebody just puts them in a wheelchair and their family wheels them down the hall, that's not allowing the person to be as independently as possible, and so that doesn't count here. We want an assessment of the person's ability to wheel 50 feet with 2 turns. So we have an example here, one seated in a manual wheelchair. Mrs. R wheels about 10 feet, then asks the therapist to push the wheelchair an additional 40 feet into her room and her bathroom. So the therapist in this instance appropriately allowed the patient to do as much as possible, but once the patient indicates they need help, the therapist does provide effort, and so in this case, there was 50 feet that was done perfectly, and the patient is doing 10 feet, the helper is doing 40 feet. How would you score? Okay, I see some twos, anyone else? All right, okay, I see 2s over there, excellent. So I agree, I would score that a level 2 because the helper provides more effort than the patient in this instance. Patients can use different types of wheelchairs, and so in order for us to understand the person's ability, we'd like to know if the person was in a manual wheelchair or a motorized wheelchair or scooter. So code 1 if the person's using a manual wheelchair, and code 2 if the person is using a motorized wheelchair or a scooter. Wheeling 150 feet is the next item. This again begins once the person is seated in the wheelchair or scooter, and it reflects the ability to wheel at least 150 feet in a corridor or similar place. We have one example here. Mr. G always uses a motorized scooter to mobilize himself down the hallway, and the therapist provides cues due to safety to avoid running into the walls. So for safety reasons. So how would you code? I see 4, 4, I see a 3, 4, 4. The correct response is 4, supervision. So in this instance, the queuing is similar to the supervision, and that would be coded level 4. Because patients may use, let's say, a manual wheelchair for short distances and maybe a motorized chair or a scooter for longer distances, we do have you fill out the type of wheelchair for each item. So in case you were wondering, why didn't you ask this once? It's possible somebody uses different types of wheelchair, and so we wanted to be very clear what the code for wheeling 150 feet, whether that was motorized or a manual wheelchair. So it's a follow-up question in this instance for both distances in the wheelchair. I do want to highlight that on the admission assessment, you will be reporting, again, a minimum of 1 self-care or mobility goals. If you'd like to report goals for every item, we would love that. If it's helpful for you, you should absolutely do that, but you are, for the quality measure, only required to report 1 self-care or mobility item as a goal. And I covered the goals earlier, but just to reinforce, you can have goals where the score for the goal is higher than the admission assessment. It is equal to the admission score, or it could be the discharge goal might, in some circumstances, with somebody who has a progressive neurologic problem, the goal might be lower than the admission performance score. So this refers you back to those slides 52 through 53, which was the self-care. Want to reinforce you cannot score for the goals a 7, that the goal is for the person to refuse to do it, or the person won't be able to do it due to safety. So if, walking is not expected, you're going to be skipping out of those items, so you won't be putting goals for walking items. But you might put it for a self-care activity in that instance, if that's appropriate. I did also want to reinforce what I mentioned earlier, that in some unfortunate circumstances, a patient might have an emergency discharge, and so if there is an unplanned discharge, you actually don't need to code function, and so I guess we have an example here to reinforce it, but anyway, Mr. C was admitted to the LTAC with healing, complex, post-surgery, open reduction, internal fixation fractures, and sepsis. However, complications during the LTAC stay arise, and Mr. C unexpectedly returns to acute care, resulting in discharge from the LTAC. How would you code him? Well, the answer, it's a somewhat trick question, no function data are reported. If you look at the unplanned discharge assessment or the expired form, you'll see that there is not an opportunity to report function scores at discharge in this circumstance. So in summary, we have covered several types of questions as part of this section. Section GG assesses the need for assistance with self-care and mobility activities during the stay, collected both at admission and discharge. We do also ask about the person's ability to function and what devices they used prior to the current illness, injury, or exacerbation. That information is helpful in terms of understanding functional improvement that may occur among your patients. It also helps to set a treatment plan, and it is commonly collected by therapists on admission when they are working with patients and setting treatment goals and setting the treatment plan. Many of the items included in section GG are new, and so that includes the GG0100, GG110, and GG0130. There were previously 3 mobility items on the data set. The number has changed. That's not probably really important for you to know, other than just to recognize it. And there is slight wording change on the one roll left and right item, but the intent has not changed. The scoring would not change. So in terms of action plan, again, this is set up as a train the trainer program. We hope that you will go back to your facilities and provide some additional education to the staff. Many of the examples might be helpful for you to review with staff. Many of them are in the training manual, plus there's a whole lot more in the training manual. We will be collecting questions, so there will be in the future probably frequently asked questions that would be posted after this training session. I wanted to be sure you were aware the slides that were put on the website for this session did not have answers, but I believe the answers will be posted, but in a slide set after this session. They're also, the responses and rationale are in the manual, so you can find them either place. So you should definitely go through the 6-level rating scale, review the activity not attempted codes with the staff. You should evaluate the documentation at your facility to see about terminology consistency. So, totally fine if people are using things like distance supervision, close supervision, because that can be, anybody reviewing the chart would be able to score based on that information, but definitely it would be in your best interest to start looking at that right now, how clinicians are documenting things and making sure definitions are consistent. Again, practice coding scenarios with the staff and provide them opportunities to kind of learn just like you did today. So that is the end of my presentation, and I didn't get kicked off the stage. I got through everything. So thank you so much for your attention.